Peace be upon you. This is Dr. Ahmed Farag, consultant cardiac anesthesiologist, and this talk is about diagnostic values of transthoracic echo. I have no disclosures. By the end of this talk, I will discuss how to get the best out of echo in shortest time, diagnosing different types of shock. This is a continuation of my talk about pathophysiology of shock. And if you remember, this is a crucial slide where you should expect in hypovolemic shock to see the heart empty while contracting, in cardiogenic shock to see the heart full and weakly contracting. In distributive shock, you should see the heart full and well contracting. And in obstructive shock, you need to see the source of this obstruction. First, let's talk about how to assess a normal heart. This is a short axis of the left ventricle. And to assess the left ventricle, I want you to imagine that there is a dot in the middle of this left ventricle, and I want you to assess all the walls of the ventricle, how thick they go, and if this thickening is equal to other walls, and how does it move towards this dot. So we will comment on two items, motion and thickening. Motion of all walls and thickening of all walls. So in this normal heart, you will see all segments of the left ventricle are thickening equally, and all of them are moving equally towards the center of the left ventricle. Compare this video to this one, where there is a dot also I put in the middle of the ventricle, but you will find the ventricle is very weakly contracting here. And this resembles left ventricular dysfunction. This is a four-chamber, apical four-chamber view, and the same principle applies here also. We need to comment on two items, motion and thickening. How does all walls move towards the center of the ventricle? And what about the thickening of all walls? Are they equal thickening? Is it adequate or not? So this is a normal four-chamber view, and compare it to this one where you will find the ventricle is not moving well compared to the other one. Okay, so this also is left ventricular dysfunction. The same applies here also. This is normal, but what's wrong with this ventricle? You will find that some walls are moving well, others are not. As you see here, these walls are not moving well. Other walls, they move well and there is adequate thickening in them. And this resembles regional wall motion abnormalities. Now I will discuss how to assess the right ventricle. Normally, the right ventricle does not form the apex. The apex is formed by the left ventricle. So the right ventricle is usually in size less than the left ventricle. Actually, it should not exceed 2/3 of the left ventricular size. Moreover, the most lateral part of the tricuspid valve should be here. This is the tricuspid valve. And the most lateral part, this is called the tricuspid annular plane, and it should move towards the apex with each systole. So this is called tricuspid annular plane systolic excursion, and this is important to assess the function of this right ventricle. As you see here, the tricuspid annulus moves towards the apex with each systole, and there is also the same principle of motion and thickening on the right ventricle. Compare this normal video to this one, where initially you will find the right ventricle is enlarged. It is participating in the apex even more than the left ventricle, and you will find it larger in size than the left ventricle, and the contractility here is normal, is not so depressed. So this is a sort of right ventricular dysfunction. The left ventricular function is normal, the right ventricular function is not. Another important sign, if you see here, this short axis view of the left ventricle, is not very normal. I will freeze one of the frames and you will find the left ventricle looks like D-shaped ventricle. Actually, this is a sign of ventricular, right ventricular pressure overload or volume overload. Okay, so this is a D-shaped ventricle. Next is an enlarged right ventricle. As you see here, the apex is formed equally with both left ventricle and right ventricle, but the right ventricle moves well, and this means that there is only right ventricular dilatation, but with normal right ventricular function. This is how to assess the ventricle for possible left ventricular or right ventricular dysfunction as a cause of cardiogenic shock. Another example here, this is enlarged LV, also this D-shaped left ventricle, but the right ventricle moves well. So right ventricular dilation. I want you to focus here, and you will find here there is something in the middle of the right ventricle here, and you may also find something floating in the right atrium like this one, and the RV is not well contracting. Both of these signs may resemble pulmonary embolism. Further diagnostic tools may be needed, but this is highly suggestive of pulmonary embolism according to clinical scenario. This is a parasternal long axis view and it looks normal. I want you to see this structure. This is the descending aorta. And now I will discuss the next cause of obstructive shock. This is the pericardium. And if you find fluid accumulating between this white line and the heart, it will resemble pericardial effusion. And if you find the fluid accumulating beyond this white line, it will be a pleural effusion. Pericardial effusion may also cross on front of the descending aorta here, but pleural effusion usually does not cross on front of the descending aorta. This is an important to distinguish between both. So this is a parasternal long axis view, and you'll find here fluid adherent to the heart, and it is almost passing on front of the aorta here. And this is the white line that we were discussing. So this is fluid accumulating inside the pericardial sac, or the so-called pericardial effusion. On the another example will be here, and you will find here the heart is weakly contracting. This is the white line we were discussing, and there is fluid accumulating, but beyond the white line, which resembles pleural effusion. Okay. This is a subcostal view, subcostal four-chamber view, and if you, I want you to compare it to this view, where you'll find the whole heart is dancing or moving, contracting inside, a huge amount of fluid circulating the whole heart, and this is, of course, pericardial effusion, but there is one more very important sign. You'll find the ventricle and the atrium here are not regaining their full size volume. This means that there is a collapse of the right ventricle and right atrium, and this is a sign of pericardial tamponade. And this is the normal short axis view of the ventricle, and you'll find here also huge amount of fluid accumulating in the pericardial sac, and the right ventricle is collapsing with the pressure of this fluid, and this also a diagnosis of tamponade. Now this is a normal parasternal long axis view of the heart, and here this parasternal long axis, you'll find easily that the septum here is hugely dilated. This is a huge interventricular septum. And if I zoom in with the view, you'll find that the mitral valve that lies here, the anterior mitral leaflet, this one is obstructing the left ventricular outflow tract, and this resembles hypertrophic obstructive cardiomyopathy with systolic anterior motion of the mitral valve. So now we discussed cardiogenic shock and obstructive shock. I will shift to next, and this is, this is transesophageal echo view. I want you just to get the principle. This is transesophageal short axis view of the left ventricle. And compared to this image, you will find that the end diastolic and end systolic volume are very low in this patient. And according to the scenario, you can understand that this patient is severely hypovolemic because end diastolic volume is very low. Uh, to distinguish the pathology of hypovolemia, I want you, when you find a suspicious case like this, you freeze the screen and try to measure the end diastolic diameter of the ventricle and end systolic. As you see here, this is the end systolic, and there is almost total obliteration of the cavity during end systole. And the next example, of course, is the similar example I will show you. Now, this ventricle. You will find also there is almost kissing of the papillary muscle and near total obliteration of the left ventricular cavity. However, there is some volume at the end systole, at the end diastole. Sorry. So, if we freeze the image, at end diastole, you'll find here there is some fluid, some blood inside the heart that is not very empty during end diastole, but during end systole, it is very empty. I want you to compare this to hypovolemia. In end systole, both ventricles are nearly totally obliterated, but in end diastole, the hypovolemia is obliterated. The distributive shock is not very well is not very hypovolemic, is not totally obliterated, as you see here. So the most important factor to distinguish between distributive and hypovolemic shock is to find the difference in left ventricular end diastolic area or diameter. So now we discussed both final types of shock. This is another normal parasternal long axis. I want you to compare it to this one, parasternal long axis, but there is something here in the ascending aorta, and the ascending aorta looks dilated, and this is another quite rare cause of shock, this aortic dissection. So with the help of transesophageal transthoracic echo, we have successfully diagnosed almost all types of shock, in addition to dissection and some causes of hypoxia. The role of transthoracic echo in distinguishing different types of shock is very obvious. Thank you very much.